violates everything I always believe, that patients actually have to get some real doses of systemic therapy in the impact. But the trial does not allow that. You can't give, if you follow the design of the study, you cannot give the 2 full doses of carboplatin-paclitaxel as in the Japanese study. And again, this issue that there is no overall survival benefit, although I would say that that's yet. But it's clearly the new standard of care. The bar here is very high. If you're going to not offer this to someone, you've got to have a pretty good reason not to do it. This has put a huge problem into the management of patients with stage 3A disease that we approached with surgery. And I'm going to review the literature quickly, but although I never asked this to Jack, I'm sure that at Swedish, they do operate in patients with stage 3A disease, depending on the patient's characteristics. And that's despite the fact that this is the American version of the question. Patients treated with cisplatin and etoposide plus 45 gray of radiation therapy are randomized to have surgery or to complete their radiation therapy, and the trial is spectacularly negative from a survival standpoint. You could try to break down and say, well, what if they have a pneumonectomy? Then it's worse to have surgery. What if they had a lobectomy? Well, then it's better to have had surgery. But the trial was negative. Despite that, many academic medical centers would still offer surgery for patients with stage 3A. So this is from a paper that we published from the NCCN non-small lung cancer panel on the management of patients with stage 3A. And I'm going to just go straight to the questions. What's the threshold for you to operate somebody? So we asked if the NCCN institutions would consider surgery for patients that have one mediastinal station involved, and that lymph node is less than 3 centimeters, which means that it's non-bulky. And 90% of the NCCN institutions would say surgery. Well, what if the patient has more than one lymph node station involved? So they have a subcarinal lymph node and they have a 4L involved. Would you still give them surgery as part of their therapy? And that broke kind of half and half. And then we took one step further. What about if it's more than one station, but it's also bulky? And there were still some 16% of diehards that said, sure, we'll operate with those patients. And those are NCCN institutions. The position of the NCCN panel is that if you don't have access to a surgeon that has most of his or her practice dedicated to lung cancer, surgery for patients with stage 3A should not be occurring at your institution. So that brings the question, and actually we don't have one of those answering things, but you can just keep it in your head. What would you do? So this is a 55-year-old man, current smoker at the time of his diagnosis, so 40-pack year. And believe it or not, he swears he had no symptoms. He went to see his primary care physician and said, you are a candidate for CT screening. And he said, okay, I'll do a screening. And then he had this humongous mass in his chest, measuring 7.3 centimeters. So that's really not the kind of cancer we're going to pick on the screen, but great. So he felt great and had no symptoms and an ECOG performance status of 0, had some history of coronary artery disease, and the biopsy showed a squamous cell carcinoma with this questioning why a biopsy was performed. I think that there was, based on the size of the mass and being a more central mass, there was some concern that this could be small cell, or that the patient didn't have intestine involved. Anyway, the PET scan showed that this mass was hypermetabolic, had a central necrosis, and extended into a conglomerate of lymph nodes in the left hilar area, and there was some suspicious involvement of the left pulmonary artery as well. For MRI was negative, and the surgical evaluation considering him to be borderline resectable. As we do occasionally for patients that are young with a good performance status, the decision was to treat him with full dose chemo and radiation therapy, and then make a decision regarding surgery after the completion of full doses of radiation, which we have published data in our institution that that's safe. So obviously on the right, your left, you have the initial scans showing the very large mass, and then the central necrosis, very hypermetabolic. And then you have the follow-up after the completion of chemo and radiation therapy with some central cavitation of the mass, and although still activity on the PET scan, much less activity than initially. So the question is, what to do now? He did have a PET at the completion of chemo radiation therapy because he was part of a study actually, and that PET showed no evidence of distal metastatic disease. He completed therapy with an ECOG performance of 1. He was still working full time. He works in a fancy restaurant in town parking cars overnight, and then he comes in the morning, gets a start, and goes home to take a nap. So what would you do now? Would you treat him with durvalumab? What about 4 cycles of pemetrexed followed by durvalumab? What about their lockdown for a couple of years? Does that sound like a good idea? Or surgical resection? So we don't have one of those systems. I would say that B and C are not correct. One, because in this scenario there is no evidence that their lockdown makes any difference. And B, because this patient has squamous cell carcinoma, should really be treated with pemetrexed. Well, you know what we did, right? We operated. So he had a mediastinoscopy, which was negative, and the final path showed that his 4R, 2R, 4L, 10L, 7 were all negative, and he had 10 left hilar lymph nodes that were all negative. He ended up requiring a left pneumonectomy. And the tumor had no viable disease either. So we had a complete pathological response and ended up having a left pneumonectomy. I mean, obviously, with a mass this large, did he really have a complete pathological response? How many sections do you want to do to prove that there were no cancer viable cells at all on the mass? Who knows? But what would you do now? 2 more cycles of chemotherapy? It seems super sensitive to chemotherapy. Nothing else? Did great. Couldn't do any better than that. What would you do durvalumab for? And I would say that, excluding the 2 more cycles of the topocyte, which I absolutely would not do, although I could see the rationale if something felt very strongly, I actually don't know what the answer is. Should this patient be treated with durvalumab? Again, if he had not received surgery, he should have started durvalumab way back then. Should we deny that option to the patient? And I think that this case brings this issue of how should we manage patients with stage 2A that end up having surgery? And I think that that's a question that is very much open. Have you had to face that question yet?
We have some. I would say
Yeah, I think that that's incredibly hard. I share with the patient all the uncertainties regarding this, and he's like, I'm getting bad news. So he's receiving the roadmap and tolerating so well, continues to work every 2 weeks. He shows up. Is that the right thing to do? Who knows? So I think that that's all I have for today. As I said, I have to run back to the Spokane airport. So more than glad to take any questions. I have 6 minutes before I make Dr. Wesker late.
So you said that your personal view is you couldn't see how it is not to give folks full systemic therapy rather than just their chemorabs with the weekly carbotaxol. So off of the clinical trial, when you have that patient, what would you do?
No, you have to surrender. Sometimes I think that as you get as old as I am now, you learn that sometimes you just lost the battle.